Good evening, aspirants. Good evening, sir.
Good evening.
So once you are ready, we can start. Okay.
Yeah, I'm ready. I'm starting.
Okay, start.
Good evening, everybody. So today we shall be mostly be dealing with the some basic topics of EDIC Part 1. So since the option was given to me regarding choosing the topic, so I chose some out of the box topics which are asked in the exam, but we generally we give less importance to it. So we shall be discussing a bit about brain death, post ROSC management of a patient in ICU, and a bit of an introduction like session to organ donation. So without further ado, we shall be starting the sessions. So suppose a patient has come to you, something 40-45 years old male patient has come to you post a road traffic accident, and the patient is of course in a coma. There are multiple injuries. There's a head injury also. You have done an MRI brain, and there is a diffuse injury with subarachnoid hemorrhage in ICH, etc. And it's been around 30 hours, and the family members want you to, give them a prognosis about the patient. So then the question arises. So because EDIC 1 is also like it moving towards a very clinical based. So it's almost always a case based question is being asked there from brain death. So then the question arises that how do you test for brain death, right? And once you have tested for brain death, then like how do you confirm the brain death? And in some situations where of course the apnea test and is not conclusive, then what do you do? So we shall be discussing those now. So firstly, we shall be discussing a bit about brain death. Yeah. So how do you define brain death? Brain death is mostly defined as that there should be an so there should be an underlying cause, irreversible brain injury to the CNS, right? Injury to the CNS, by CNS I mean brain. And there are some things which need to be ruled out. So hypothermia needs to be ruled out. Any electrolyte imbalance, gross electrolyte imbalance, any gross acid base thing like that is the met acidosis or severe metabolic alkalosis, those things. We also need to rule out any obviously sedatives and paralytic effects, any poisonings, right? And any other co-founders that can be dealt with case to basis. Co-founders that we want. So these things needs to be ruled out first. And questions are asked on the basis of this also, because in a stem there will be a 7-line stem, and somewhere it will be like mentioned that the core temperature was found to be 32.8 degrees Celsius. What do you do next? And one of the options will be something like wait for some time. So on the basis of that, you have to select that wait for some time option, because that will be like once the temperature needs to be normalized, right, between 34-35 degrees Celsius, then you can proceed for brain death testing. So once the underlying cause is there and these conditions have been ruled out, then you proceed for brain death testing. As I said, core temperature should be at least 35 degrees Celsius or more, and these things we have discussed. So once that is done, then we need to check out these reflexes. So the third point is absence of brainstem reflexes. What are the reflexes? For EDIC part 1 or part 2 even, just the names of the reflexes are good enough. Pupillary reflex, corneal, oculocephalic, vestibulo-ocular, and calf reflex. And which cranial nerves are involved, that also need to know. That's a bit theoretical, and that is very rarely asked in EDIC part 1. And how the reflexes are tested, those things are, are out of the scope of the exam, because it's an MCQ based exam, so nobody is going to ask you like that. And finally, we come to the apnea test. Most of the MCQs are from these ruling out these co-founders and the apnea test. So to perform the apnea test, the patient must have a normal blood pressure, normal body fluid content, and then almost a normal temperature. The PaCO2 should be between 40 to 50 and a satisfactory oxygenation. That is, the PO2 should be at least more than 65-70 range, and the saturation should be around 90%. Those type of things should be there. Again, to rule out the confounders. And once we do that, so what do? We put a cannula within the trachea and we supply oxygen at full rate, 10 to 12 liters per minute, and then we disconnect the ventilator. So once we disconnect the ventilator, we look for any spontaneous breaths of the patient, and if there is spontaneous breath, then of course the test is negative, and then we just put the patient back on the ventilator. But if there are no spontaneous breath, then what do you do?
পিছনে যেটা করছেন ঠিক করছিল বস ওর পিছনে সামনে কোনো ব্যথা হয় না কেন
So
মুখটা বন্ধ করতে পারিস না
please mute yourself.
দুপুরবেলা এই তেলটাই তুই মাখিস সেজন্য সকালে আমি মুখ
The minimum PaCO2, so after 10 minutes we check the PaCO2 level, and the minimum PaCO2 level should be more than 60 and more than 50 and more than 60. So why are they very different? Because of the difference in the guidelines, American guidelines, British guidelines, Canadian guidelines. I think for all practical purpose we are following the British guidelines because it's an European exam. So 50 should be good enough. If that is not in the option, we'll always use 60. This 20 millimeter marker rise from baseline is very important. Suppose PCO2 was 45 and then the delta PCO2 becomes 65. Then its PCO2 is already more than 60, so there is no confusion. But suppose PCO2 was 40 and then there is a rise of 20 and the baseline becomes 60. So then by this criteria, the apnea test is still it's a negative apnea test, right? So brainstem death testing is positive, although the PCO2 is 60, only 60. So this is about the brainstem death, and these values are asked: what is the normal, what is the PCO2 level, and this delta PCO2 change. These things are asked in the exam. These are all MCQs. Now suppose the brainstem death testing is negative, or you could not do the brainstem death testing because you had to early terminate. What do you mean by early termination of the brainstem death testing? The patient became hemodynamically unstable or the saturation dropped below 80%. So you had to cancel the brainstem death testing. So then what do you need to do? You need to do the ancillary tests of brainstem death. So what are the ancillary tests? One is the EEG. The second one is the MR angio of the brain. The third one is a transcranial Doppler, or you can also do the CT angio, of course. So these are some of the ancillary testings of brainstem death. So EEG, MR angio, CT angio, transcranial Doppler, and these tests are only to be done if the apnea test you cannot do or is inconclusive. Okay, so this was about brainstem death, that is how to conduct the brainstem death testing. This is very commonly asked in the exam. Lots of MCQs are available, there can be asked, and just a minute. Lots of MCQs can be asked from these factors which need to be ruled out. The temperatures, which is an exam favorite, the core body temperature thing. Then the brainstem reflexes you need to rule out, and of course the apnea test, and finally the ancillary test of brainstem death. So once we are done with that, so suppose now, so this was case number 1. So the same patient who has come to your ICU and you have done a brainstem death testing, and now the brainstem death testing is negative, right? So the patient is not brain dead. So you wait. So your plan is that you shall wait for 72 hours, then you shall do an MRI, and you shall see what happens. In the meanwhile, between the 36 to 72 hours, that is the 36 hours that you gave to the patient's relatives, the patient is arrested, and we have followed the protocol, and we have given the the ACLS guidelines protocol, the chest compressions, the ADRs, and everything, and the patient has been revived. The ROSC has been achieved. Now we come to the second part of today's discussion, which is also very commonly asked in the exam: post ROSC care of ICU patients. Yeah. So what's your initial management plan? So again, I have divided into 3-4 headings for easy, so that you guys can easily remember it. So suppose there is a post resuscitation care you are doing. So the very basics. So number one is airway and breathing. Saturation target 94 to 98. These patients, of course, those are intubated patients. So you just increase the oxygenation or you adjust the ventilation so that the saturation is between this level. And the patient is intubated for all practical purposes. So this line is not there. Waveform capnography is a must. Again, a very commonly asked question. I think a couple of years back they gave a picture, and this was post ROSC care, and they asked what is missing. So there was no waveform capnography, and the answer was waveform capnography, which you needed to be added. So these are the guidelines. Okay, these are direct screenshots on the guidelines. So each and every line can be an MCQ. So this is airway and breathing, and the target is a normocapnia, that is a PCO2 around 40. Then we come to the circulation part. ECG need to be done. We also need to do an echo, of course. Although post CPR, echo is not very reliable because the heart may be contracting very slowly. SGP target is more than 100. Of course, you have to do a POCUS and restore normovolemia, IABP, and consider vasopressor. So from here, most of things are obvious. The only thing is that the target SBP is more than 100. This can be an MCQ. Otherwise, normovolemia, IB monitoring, SVP saturation at least more than 65. I mean, the MAP more than 65. These are pretty obvious things. I don't think they are going to ask that in the exam. But coming to the most important thing, just like brainstem death, again, the temperature part is very, very frequently asked in the exam. So the target temperature is 32 to 36 degrees Celsius. We shall be discussing in the next slide. You do not need to target hypothermia. You just need to target normothermia, prevent seizures, prevent fever, and prevent shivering. That is it. So control shivering, because that increases the oxygen demands and everything. So once you've done the basics, you need to do 2 investigations, because the cardiac arrest for all practical purpose can be related to the heart or it can be related to the brain, right? So you need to rule those 2 out. So you are doing a CT brain, or you are doing a 12-lead ECG, and you are seeing an ST elevation. If there is an ST elevation, you have to go for a coronary angiography plus minus a PCI, right? And if that is not the case, if another cause for cardiac arrest is identified, you can manage that cause, or you can process for a CT brain, because a 12-lead ECG can be done at the bedside. So this is usually the first line investigations. If this this pathway, this is the cardiac pathway, this you think that this cardiac pathway is not suitable for this patient, then go for a CT brain, provided the patient is safe for transportations. And if you think it's a pulmonary embolism, then you can go for a CTPA also. So these are the 3 investigations that can be done. So again, an MCQ, CT brain, and ST elevations on a 12-lead ECG. These are the 2 pathways that you have to follow. If both are negative, if one of them is positive, then it is either a stroke pathway or a PCI pathway. If both are negative, then you admit to the ICU and you find out what mostly supportive management, and you try to find out any other underlying cause. So what is the ICU management? Once again, the temperature is same, 32 degrees to 36 degrees Celsius target, and prevent shivering, prevent fever, normoxia, normocapnia, avoid hypotension. Now do an echocardiography, because there has been some time, and probably now we'll get a better idea of any RWMA or any any severe MR, severe TR, about the LVEF, about the TAP C, those sort of things, which I think everybody of all of us do in the ICU. Maintain a normoglycemia. Again, the previously asked question. One of the question was what is the target, and normoglycemia was not mentioned, so we need to do that. And this is very, very important. This is the most frequently asked MCQ from this part. Delay prognostication for at least 72 hours. 72 hours, you need today also, like day before yesterday, a patient has come to our ICU, post CAPG patient, cardiac arrest, and 20 minutes CPR, ROSC, and the family members, of course, they want to know the prognosis. So today also I told them that still not 72 hours, so we shall wait till 72 hours, then we shall do an MRI, and then we can give you a proper neuroprognostication. Otherwise, till now, it looks bad, but that's all. Without the MRI brain, we cannot give you a detailed thing. So it's very practical. All of us have to do it at ICU at some point of time. So targeted temperature management, we already discussed 32 to 36 degrees Celsius for at least 24 hours. Avoid fever for at least 72 hours. Okay, this is very important. And this is for both out of hospital cardiac arrest and in hospital cardiac arrest with any initial rhythm. So you have done those things. Now the patient is comatose. M is less than 3 of GCS after 72 hours. So again, you have to rule out the confounders, almost same confounders as we have discussed in brainstem death. And you have to see whether 2 or more of the following are present. As you can see, there is a 24 hours or 72 hours. The MCQ comes on the basis of either which one of these are present or absent, or on the basis of this time. So 72 hours, you can see there are 3. No pupillary and corneal reflex, NAC, which you need to do at 42 hours and 72 hours, and status myoclonus at 72 hours. And 24 hours are these 3. So 24 hours is bilaterally absent N2 SSCP wave and highly malignant EEG with suppressed background or burst suppression. So EEG and SSCP, N2 SSCP, these are at 24 hours. And among EEG, it's a bad EEG, suppressed background EEG, or burst suppression EEG. NAC value is also asked, it's less 60 micrograms per liter, and you have to check it 2 times, 48 hours and 72 hours. Okay. Or on an MRI, there is a diffuse axonal injury. This, I think, all of us know, it's kind of the grave prognosis. So these are the poor confounders. Okay, nothing else. Whatever may be asked in the MCQ exam will be there in the will be the right option. Any one of these will be the right option. Sometimes they ask like a GTCS or poor sensorium. Those things are not. These things are the ones. And also remember the value of NAC, non-specific knowledge. Neural specific knowledge, more than 60 micrograms per liter. Okay. So how to neuroprognosticate? Of course, with the use of these things, but after 72 hours. So this is basically what we have discussed till now. This day's timing, 72 hours, wait for at least 24 hours, because after 24 hours, you can at least give these 2. Before 24 hours, you can't do anything. And then finally, after 72 hours, you can give the full outcomes, right? So these are the 3 scores: Glasgow Outcome Scale, Modified Rankin Scale, and Cerebral Performance categories. So if you just Google it and find it out and just remember the names, then also I think is enough. But sometimes what they do is they ask directly about the scores. So I shall share the scores, Modified Rankin Scale. Yeah. Yeah, so this is the Modified Rankin Scale. As you can see, there is 0 to 5. The 5 is the worst one, severe disability, bedridden. 0 is no symptoms, and 1, 2, 3, 4 is that, like that. So they can also ask you, giving a typical clinical condition of the patient, and ask you what the score is. Okay. So yeah, so try to know about both about the Gauss and the modified Rankine scale. I think these two are the most important ones, and it can be asked in the exam. Okay, this we have discussed the brainstem wala. So this is about brainstem death and about the post ROAC care of the patients. I have another part. Okay, so let me just check whether you guys have any questions or not. Okay, Dr. Ishora, which slide do you need to see? I saw yours now because it was full screen. I was sharing.
I got it, no problem. You
Okay,
went through all
thank
the
you.
slides, no problem. Thank you.
So, if any of you have any questions or you want to repeat something, now you can tell me. I shall just do it now, and then I shall move on to the next part of the today's class. I shall just get the next slides ready. Till then, if there are questions, I shall just solve it. Yeah, I don't think there are any questions. That's fine. So this is basically one of the continuation of what we have discussed till now, post ROAC care, brain death, these sort of things. So there are some derangements following brain death. So what are the complications can happen? As you can see, hypothermia, that is the most common, right? It appears in about 100% of cases. That's why they are giving importance in the MCQ also to the hypothermia. Because EDIC is one of the exams where whatever you can tell it's tough. You can tell that, okay, I got unlucky and this sort of thing, but you can never ever tell that they did not ask me clinical based questions or they asked me questions which you don't deal with in ICU. It's an extremely clinical question exam, both part 1 and part 2. So yeah, so if you guys are working in the ICU and you are reading something, you are joining, of course, doing this course, I think you guys can clear the exam. It's not very tough. The part 2 is a bit difficult exam, but part 1 I think is pretty straightforward for anybody who is actually practicing critical care and of course preparing for the exam with at least a moderate level. Anyway, so hypotension is second most common, 81 to 97%. So why does it happen? Because of vasoplasia, hypovolemia, myocardial abnormalities. So you need to do a focus to rule out hypovolemia and myocardial abnormalities. Vasoplasia, you can't really do anything for a brainstem death. You can just add vasopressin, right? This is one of the conditions of vasopressin you can use early, because not only will it work for the hypotension, but it will also work for the diabetes insipidus, right? So that is happening because of the pituitary damage. And of course, pulmonary edema. Pulmonary edema is very common in brainstem death. We don't give that much importance to it, but it appears very commonly. Capillary leak, blood volume redistribution, and arrhythmia because of sympathetic storm. Use beta blockers very carefully because it can just crash the patient. You can tolerate a bit of arrhythmias and a bit of hypertension, and try to control it with some other things, cooling the patients, those sort of things, avoid fever. And of course, if not, you always have to give the antiarrhythmic agents also. Amiodarone is still a drug of choice for those also. And DIC. So 1, 2, 3, 4, 5, 6 points. Arrhythmias, pulmonary edema. So this is from heart. This is how I remember. This is from heart. This is from heart. This is lungs. 2 heart, 1 lungs. This is brain directly, diabetes insipidus. This is blood, DIC. And hypothermia is generalized thing, or you can tell blood. So 2 blood, 1 brain, 2 heart, 1 lungs, right? 2 blood, 2 heart, 1 brain, 1 lungs. Very important slide. This is very commonly asked in the exam. Of course, the incidence will not be asked. It's not that sort of an exam, but they can ask you the reason, they can ask you what's happening, and they can ask you the treatment. Yeah, so what is the rule of 100? You see, this is rule of 100. It's a very gross way to remember. SGB more than 100, output target more than 100, hemoglobin more than 100 grams per liter, that is more than 10 grams per DL, PO2 more than 100, blood sugar at least more than 100 or 100% of normal. So that's what the rule of 100 is. It's not, it's asked in the MCQs, which we don't usually follow this rule for clinical purpose, but it's an easy way to remember. this is, I think, what we have discussed the part till now. You see, let's first this unresponsive patient after ROSC, suspected neurological cause of arrest. If yes, do a brain CT. If no, do an ECG, do an echo, go for a CTPA, do a CTPA or a PCI. Unresponsive after deworming, exclude confounders, brainstem reflexes, and the apnea tests, neuroprognostications. And till here we have discussed basically. After that we shall discuss later. And if there is severe cerebral edema, brainstem herniation, and then of course you can go for a neuroprognostication directly. And if brain death is confirmed, then you can go for organ donation, right? This is the one which we shall discuss next. And there is something called WLST. WLST, sorry, withdrawal of life care if the patient's relatives want, or if you think that it's not suitable for organ donation or the brain death, then of course the counseling parts and those things can happen. And the most important part, so death can be brainstem death, it can be circulatory death, right? Till now we have discussed brainstem death. Circulatory death is also there. We shall discuss that later. This is the last slide we shall discuss. Okay, we shall, yeah. So if there is a circulatory death, suppose brainstem death has not occurred, but circulatory death has occurred. So then what do you do? So suppose this is time 0 and we have gone for a WLST, withdrawal of life sustaining treatment. So from the time where we are withdrawing life support treatment till there is a fall in a systolic blood pressure, there is a gap. Okay. Yeah. And from the fall in systolic blood pressure till asystole, there is also a gap. We know that, all of us know it when we are working in the ICU. So from here, that is from the WLST till the asystole is the agonal phase. Okay, or the withdrawal phase. And from the asystole till death determination, that is the acirculatory or asystolic phase. So from WLST till asystole, agonal phase, that is the patient is in agony, right? The patient is dying, we're not doing anything. That's how you can remember it for easy remembering. And from asystole to death determination is the acirculatory or asystolic phase, right? And this is also hands off time. We don't do anything during this time, right? And as soon as the determination has occurred, we start the organ preservation. That is basically we start to cool the patient. So from here to here, we prevent hypothermia, right? As soon as the patient has passed away, we start the cooling technique and organ preservation part starts, right? So this is how you approach. Now, from when the systolic blood pressure is dropping from here till death determination, that is the cooling technique is starting. That is the functional warm ischemia time. Warm ischemia time, functional. Okay. And from the start of withdrawal of life supporting treatment till organ retrieval, you see, this is organ retrieval. That is total warm ischemia time. Okay. We have a, so this is how what happens. WLST happens, then there is systolic blood pressure fall, then there is an asystole, then there is a time period gap, the hands-off part where till the determination, then organ preservation and cooling technique starts, and then there is the organ retrieval, TMAP, and okay. And so here, this is the functional or true warm ischemic period. After the implementation of WLST, from the time of that till systolic blood pressure less than 50 or the oxygen saturation less than 70. So that is the functional or the true warm ischemic time. Asystolic warm ischemic period or primary warm ischemic time is asystole to the start of perfusion. That is the organ, that is the person is dead, is death, asystole is death, right? Till there is start of perfusion. That is till the organ has been implanted in somebody else's body, or the organ has been taken off by the organ retrieval team. Clear? Please mute yourselves. Asystolic warm period, which is also called primary. This is the MCQ. Okay? I think you guys are knowing it. Primary warm ischemic time and functional or true warm ischemic time. And total warm ischemic time we have discussed from the time of cardiac arrest to the start of preservation, which is uncontrolled, and controlled is from the time of withdrawal of life supporting treatment to the start of perfusion. Okay. So these are the different warm ischemic times. Total, which can be uncontrolled and controlled. Uncontrolled is from the time of the cardiac arrest to the start of preservation, maximum of 150 minutes. Very, very important MCQ. Controlled is from the time of withdrawal of life supporting treatment to the start of perfusion. Functional true warm ischemic time is till these two conditions are met. MCQs, right? I think you guys are understanding this. Primary warm ischemic time, again the definition, again an MCQ. So this is very important. These are very commonly asked MCQs nowadays. These don't give that much importance, right? Because they will, because you guys, if you guys are lucky or unlucky, I don't know, because these are easy pickings. So you may not get an MCQ from this part, but if you get, it's very easy to score, because they will not ask anything apart from what I'm telling you, from brainstem death, from post-ROSC care, from these ischemic warm ischemic times. And these are the ischemic times of warm ischemic, functional warm ischemic times of some organs. It's liver and pancreas is 30 minutes, lungs and kidney are 60 minutes. Okay, these are the two common ones, lung, kidney. So those are more, 60 minutes. Liver and pancreas are the lesser times, 30 minutes. Okay. Yeah. So now we shall be discussing the hormone replacement post brainstem death, because we saw that there are several problems that can occur, right? These problems. So how we can tackle it? So there are 4 hormones which can be replaced. The first one is vasopressin. This is the dose, or desmopressin intranasally has a selective action on the V2 receptors. That can also be given. Second is methylprednisolone, which needs to be given immediately after diagnosis of brainstem death and then once daily. Insulin to maintain the blood glucose between, this is the target, not 140 to 118 as in the ICU, right? It's 80 to 150. So vasopressin, so vasopressin, methylprednisolone, insulin. The fourth one is thyroxine, T4. Dose has been asked previously in the exam, unfortunately. 20 mics bolus followed by infusion of 10 mics per hour. T3 is 4 mics bolus followed by infusion of 3 mics per hour. Not too difficult. T4 is the more dose, 20 and followed by 10 mics per hour. T3 is a less dose, 4 and 3 mics per hour. Why? T4 improves hemodynamics and prevents cardiovascular collapse, right? And any contraindications is mostly a new infectious or neoplastic disease high risk with a poor prognosis. These are the contraindications for all the 3 transplants. Yeah. Okay. Yes. Okay. Somebody asked something. Please repeat confounders. Okay. Just a second. Okay. Confounders. Confounders is better. Yeah. So the confounders are mostly, hypothermia, hypotension, acid-base imbalance, severe metabolic acidosis, severe metabolic alkalosis, severe electrolyte abnormalities, hypothermia, any use of sedatives or muscle relaxants. And in this patient, you have to give a longer than usual time for the sedative action to go away, because their liver kidney, they almost never is in a proper shape. So you have to give some extra time, at least 48 hours for it to wash away. And of course, the patient should not be paralyzed. That's, I think, is a given. And yeah, rule out any poisonings also. Okay, any excess urea creatinine, any high ammonia, those things also need to be ruled out, right? Frank sepsis, because septic encephalopathy can also be there. So I think these are the topics which I wanted to discuss. I think there is some time, so this I kept an extra, basically. CCS poisoning. Okay. Okay, so the answers are not actually given here. So yeah, so let me discuss something else, because it's a general topic. So just told me that we can discuss anything that you want. So what we shall discuss is, we shall discuss poisoning only, or we can do some trauma also. Yeah, I don't know why the answers are not here, but yeah, we shall discuss poisoning only. So suppose a 52-year-old male patient with a history of CAD on cardiac medications has presented a history of headache and dizziness, and you can see the pupils are constricted, blood pressure is very low, heart rate is, there is a bradycardia going on, GCS is poor. There is a history of cardiac medications. So from there you have to understand that this is a case of a beta blocker poisoning or a calcium channel blocker poisoning, right? So once this patient presents with a calcium channel blocker poisoning, yeah, I should write it here only. So suppose it's a CCP poisoning. So what is the management of CCP poisoning? So first is airway breathing circulation. I won't go into that. The second is any role of gastric lavage, right? Everybody is worried about gastric lavage. Very simple. If the patient presents within 4 hours, you can give it a try. If anything more than 4 hours, there's absolutely no reason to do it. That's as simple as that. Okay. The third thing is how to control the heart rate and the blood pressure. So there is some specific management of CCP and beta blocker poisoning. One of them is to give calcium, replace calcium. You can give calcium chloride or a calcium gluconate, right? Calcium gluconate, if you are giving, is 10 ml 10%. If calcium chloride you are giving, it's just 3 times that, because the potency is more. So calcium you are supplementing. If the heart rate and the blood pressure is very low, like here there is a severe drop in blood pressure and there is a bradycardia, you can start an adrenaline infusion, or you can go for a temporary pacemaker. So that's how you control the hemodynamics. As far as specific management goes, apart from the calcium, you have to give a high dose dextrose insulin. Insulin is the main treatment. High dose insulin, 1 units per kg body weight. So 60 kg, it's 60 units per hour. And accordingly, you have to replace it with like 50% dextrose, so that the patient does not go into hypoglycemic shock, right? 1 unit per kg per hour. That is the maximum dose. You can go for 0.5 also, 0.5 to 1. So one is calcium. The second treatment is mostly insulin, and you have to add the 550 dextrose, so that the patient doesn't go into hypoglycemic shock. The third thing is the glucagon, of course, which is a very specific management. If it is available, it's very good. It works like magic. I have used it many times, so it works very nice. But yeah, the availability is limited. So just you need to remember the names: calcium, insulin, glucagon. The fourth thing is lipid, intralipid, right? Intralipid, because it acts as a sink, and attracts the CCP molecules within it. What is the role of hemodialysis? There is no role of hemodialysis because the CCP calcium channel blocker poisonous, those are not dialyzable. The exception, there are some exceptions. If the patient somehow has taken those, then you can go for it. But the usual amlodipine calcium channel block and other calcium channel blockers like the linidipine, nifedipine, those things are not dialyzable. So there is no role of hemodialysis. Okay, if some other reasons like the patient has gone into an anuria, the liver has given away, then you can go for dialysis, CRRT for those indications, but not for the poisoning as such. And yeah, so that is the management of CCP poisoning. Beta blocker poisoning is the same thing. Okay, it's the same drugs: calcium, insulin, dextrose, glucagon, and interlipid. Calcium possibly a bit less role, but you can still give it because it increases the myocardial contractility. The insulin, what it does, it gives a good myocardial biochemical milieu, and that helps in replacing the insulin. Basically helps in the electrolytes to go through in the myocytes, and that helps in the myocyte health, and that's how it acts. Calcium, insulin, glucagon directly myocardial contractility, interlipid I told. So that's the mechanism of actions. So initial management I said, there is this activated charcoal. What's the role? I said. So this is basically for my EDIC 2 batch. So some of those questions I don't think you need for EDIC part 1. Treatment I discussed, glucagon hyperinsulin therapy, and treatment of QRS prolongation, very important. So suppose the question is not on the basis of management of poisoning as such, but what do you do if there is a QRS prolongation? So the basic thing is that you need to give bicarb, and you need to give magnesium. You need to see whether you are using some drugs which are causing the QRS prolongation, and you replace the electrolytes. That is the only management. Okay. Role of ECT, that is hemodialysis, I discussed. There is no role. ECMO you can always use, because in a VA ECMO what will happen, the VA ECMO is very useful because if you just can make the patient pass over the half of the drugs, that is whatever it is, 48 hours, 72 hours, and it goes out of the system, and you support the heart for that, then of course the patient will recover, right? Because there is nothing else wrong with the patient. So an early VA ECMO, if it's available, if the patient's finance is there, it's very nice. CCP poisoning, VA ECMO is pretty standard of care if it's an ECMO center. Lipid emulsion therapy we have discussed, and prognostic markers are pretty standard prognostic markers: port, GCS, hemodynamically unstable, the dose, the type, whether it's lipid soluble or lipid insoluble, and by chance if it's a dialyzable CCP, then of course the prognosis is good, because then you can actually use the hemodialysis. So that's what I wanted to discuss today. I think that I was asked to do a 40-45 minutes class. I tried to pack in as much amount of information as I could, and I hope you enjoyed the class. If any questions, you guys can ask me. So regarding preparations for EDIC part 1, what you need to do is that of course you are doing the Farz Academy thing, the Farz Academy course. So you need to follow whatever they are teaching, the other classes, the other faculties and mentors, and you have to keep on practicing MCQs. Okay, because the MCQ based test, so you have to keep on practicing MCQs. There is a ESIACM Academy, there is a EDIC part 1 crash course. Do that, it's very useful. And follow any one materials. I think if you are not following any books till now, I don't know at which level of preparation you guys are. You can do the Washington manual. It's very easy to read. It's small chapters with nice flowcharts, easy to keep in mind also. And when you are going to work, coming back, or if you have free time during work, you can just go through it. 2-3 chapters you can do it, at least 2-3 flowcharts you can do it at once. And try to read up everything. Don't only focus on cardio, neuro, and recipe, the glamorous things. Try to read the things I taught today, because those questions will be asked. Poisoning, and briefly about ECMO and CRRT, because EDIC part 1 में तो उतना नहीं पूछेगा probably, but yeah, just the types of ECMO and the cannulations and indications, a bit of the trials, Caesar trials, Eolia trials, a bit of Murray scores, those sort of things can definitely be asked. And CRRT, the indications, contraindications, types, the mechanism of actions, the benefits of CRRT over those things, that is can also be asked. So try to read those things, those which are recently coming, which are becoming almost standard of care. CRT is a standard of care now, no doubt about that. And of course, ECMO is coming up. IABP, the graphs, what is what, how to, troubleshoot it, those sort of things. Gastro and renal also. Gastro, I don't know why people read less of gastro. I don't know why, because gastro, there will be at least 4, 5, 6 questions in the exam. So believe me, read gastro. Pancreatitis, upper GI bleeding, those liver failure, acute liver failure, ACLD cases, those mesenteric ischemia, very important. Trauma, the guidelines and trauma, those things. Cardio, neuro, renal, respi, everybody knows what to read. I am not going through that. But I feel last 2.5 hours of teaching EDIC part 1 and part 2, these are the parts where people, especially trauma and poisonings and these these ACLS, ATLS guidelines and whatever the topics at least I heard today, these are very neglected but very frequently asked in the exam. You will get at least 7, 8 questions from these topics, the neglected ones. Those are very easy to score because those won't be difficult questions. Cardio say nobody knows what they will ask. So after 15 questions that they will ask from cardio, 10 will be difficult ones, 5 will be easy ones. So use your time wisely. And I think I shall do I think I shall do renal or liver, some one of those topics later on, a full-fledged topic, 2-3 classes on that. So I think we shall meet again on during those sessions. I hope you like the sessions. If you have any feedbacks on anything, you want me to do something extra in next class, do share it with Farz Academy. I shall try to incorporate that. Thank you. And I don't think you guys have any questions, so thank you for that also, and good night. Till which time GI drip should be given for beta blocker poisoning? GI drip, you mean the insulin dextrose thing? So till the beta blocker poisoning effect has gone off, right? You will see the heart rate is improving, the blood pressure is improving, or the or the clinical improvement part. Liver is better, yeah, but that depends upon whatever I am given. Liver is my favorite, one of my favorite topics anyway. So yeah, we shall see. Thank you guys. Good night.